so our next speaker, Dr. Andrea Kua, so we'll be speaking, we'll discuss therapeutic drug monitoring of beta-lactam antibiotics in Singapore. So Dr. Andrea Kua received her B.Pharm from National University of Singapore in 1996. She then pursued her Doctor of Pharmacy degree from the Albany College of Pharmacy, the US in 2006. She specializes in critical care medicine, infectious diseases, and antimicrobial research. Her main area of interest is infectious diseases or antimicrobial resistance research, particularly in treatment against extreme drug-resistant gram-negative bacilli. So Dr. Kua has authored more than 100 publications, and I'm extremely honored and thankful that Dr. Kua will be presenting today. So Dr. Kua, the screen is yours.
Okay, thanks. Let me share my slides. Thanks for having me today. Good afternoon or good evening all. So I'm going to go through the beta-lactam therapeutic drug monitoring that we have in Singapore, and this is our own little local experience, how we begin. All right, let's start. So we know that regulatory approved beta-lactam dosing regimens are actually no longer relevant in this day and age, especially for Singapore in this region, Southeast Asian region. We know because of the multiple publications that come from Prof. Roberts, augmented PK, so on and so forth. We know that the current dosing regimen, if we were to use in these patients, it is not going to be very appropriate or adequate. All right, then there is also the risk classification of beta-lactam as into an intermediate category that is now called susceptible dose dependent, that means SDD, which means if you increase your dose, you'll become susceptible in terms of your bug and antimicrobial interactions. And also, we have a rising antimicrobial resistance with limited novel antibiotic agents in the horizon, all right? And because of that, we need to make sure that we actually maximize our current armamentarium, mainly actually in your beta-lactams. Hence, actually, we need higher beta-lactam doses, which is not going to be found in your current manufacturer's recommendations, right? So hence, we need TDM to help us individualize those. I'm sure this is all pretty well known. All right, we know all this time above MICs and time-dependent, concentration-dependent effect. So for bactericidal activities, this is what we have known so far. Okay, so for maximum bactericidal activity for tissues penetration, is about 4 to 5 times if you're talking about your beta-lactams. For prevention of resistance, well, the ballpark is about, you have to hit above 6 times MICs. And this is what we have currently, all right? These are the literature out there. And specifically in patients with pneumonia, all right? Because of the penetrations of beta-lactams into the lungs or the ELF is about 20% or so. Hence, actually, your time above MIC has to be 100%, 5 times above the MICs to be actually somewhat adequate. So we don't know where we are. Hence, we started this study called BLAST-1 to find out what are the drug levels of meropenem and piptazole in our Singapore critically ill cohort. Okay, so this is just to determine whether there's feasibility and utility for beta-lactam TDM to be carried out in our setting. So it's a multi-center studies. We involve the 3 acute care tertiary hospitals in Singapore. So these are our recruitment rate. So this is how we take our levels, the sampling schedule. So we do not just do the 12. We want to know, want to work out the time above MIC as well. Okay. And what do we use? We use LCMS to measure the levels. So this is our data. So these are the demographics of those patients that we have recruited. We have all the general type of races that we can find in Southeast Asian. They are generally pretty not so young patients, and they are not typically the obese type that we normally note in Caucasian cohort. These are their body mass indices. Their 1000 CCI index is actually pretty high, and their Apache score is actually phenomenal. They are really critically ill. So if you look at the creatinine clearance, their baseline is as such. Their beta-lactam dose has been described there. Almost all of them, especially meropenem, is administered as extended infusion over 3 hours. For pip-tazo in Singapore General Hospital, most of the time, at about more than 90%, is infused over 4 hours. All right, with other hospitals, it may not be so. So most of them, the beta-lactams here are being used as a culture-directed therapy. So the types of infections that you see here with pneumonia, the most predominant ones. Okay, and they all have some form of supportive therapies for renal replacement. So the peak and trough that we achieve with our already a pretty aggressive type of dosing is as such, and do note the standard of deviation is pretty huge. And with the justification with this type of standard deviation, it already tells you that we need to do TDM because everybody handles beta-lactams differently. All right. So we also use TDM to assist in ruling out beta-lactam adverse effect. So one patient actually developed seizures on day 4 of meropenem, but eventually we can attribute it to IVIG infusion because the meropenem peak was at 37, the trough was 7. So we know that with that kind of concentration, it's unlikely that the patient developed seizures predominantly due to meropenem. So how did we attain our, how good are we in attaining our generic targets? All right, if we looked at the 40 to 50% time above MICs, all right, we are pretty good at 94% because the doses that we use is pretty aggressive. And for 100% time above MICs is about 86%, pretty good. All right, but if we are talking about even more aggressive targets at 40 to 50% time above 5 times MICs, all right, for deep-seated infections, pneumonia, and so on and so forth, we are not doing that well. If we're looking at 100% time above MIC, above 5 times MICs, we are doing it poorer. So this is what we have found out from this little study. Next. Okay, so we decided to actually develop a model out of it and look at what is the risk factors for mortality. So for all-cause 14-day mortality, so we found that if we fail to achieve 40 to 50% time above MIC within 48 hours, the likelihood of the patient to die is actually much higher. And if we, so this is, we can't prove mortality, casualty for adequacy to mortality in a direct way, but we have associated in an epidemiological way. So how about if the aggressive target? So we found that if we achieve 100% time above 5 times MICs, all right, among the survivors, there is a reduction in the length of hospital stays, which means a median of 14 days versus 58 days, all right? So, and this is huge because if you have adequately treated the infections while the patient is within the ICU, okay, actually they can potentially reduce the length of stay. However, there is a lot of challenges in correlating more aggressive targets with clinical outcomes because some of them may not have MICs derived, and we have to assume the most conservative breakpoint, MIC, for patients without cultures. So what does BLAST1 teach us? We know that from our current local beta-lactam dosing practices, it is sufficient for less aggressive targets. but it is still suboptimal for more aggressive targets. And we do know that now from this little study, the utility and feasibility of beta-lactam TDM is in very complex pharmacokinetics, high infection burden, deep-seated infections, immunocompromised states, pathogens with high beta-lactam MICs, concerns with adverse events. So this is the area where you will reap the highest return for your beta-lactam TDM. So from BLAST-1, we decided to do a BLAST-2 study. This time around, it is not just a mere observational study, it is an interventional study. All right, so the objective is to determine the feasibility and utility of beta-lactam TDM in patients within and outside ICUs, including patients with various modes of dialysis, febrile neutropenia, multi-drug resistant organisms, deep-seated infections. All right, and it is still ongoing. We samples now, we do TDM for a wider range of beta-lactams, not just meropenem and piptazole. To date, we have about a recruitment of about 90 patients. So what targets do we use for this study now? It's individualized. If the patient has deep-seated infection or at pneumonia, we will use 100% to achieve above 5 times the MICs. It also depends on the severity of illness, immune status, MICs, and patients' changes in PKs as well. So generally, this is what we are going to use in this study. This is why I've listed out the targets here. Okay, we even incorporate the protein binding inside here. We adapt these protein bindings from literatures in critically ill patients. So I will not bore you with the details and have time limit here. So summary, the preliminary findings is such that, all right, because we use mainly CVV-HDF, so we found that in non-anuric patients, we need to use this dose for meropenem. If anuric patients, all right, we can actually reduce a little bit, but you still need to stay within 1 gram Q6 to 8 hours. If it's just CVV-HD, you can stay as 1 gram Q6 to 8 hours. With SLED, our dosing has to be this aggressive, 1 gram Q12. With hemodialysis, it has to be 1 gram Q12 as well. PD, we can also go up to 1 gram Q12 for the type of dialysis that we use in our hospital. Likewise, for piptazole, we found that if a patient has a CVV-HDF, non-anuric as well, the dosing has to be minimally in this region, all right, and so on and so forth. So basically, this forms the basis of where to start right now for our patients in ICU. All right, and we do look at cefepime here as well, and astronome, and even more. All right. Okay, so in this BLAST-2 studies, after we have our levels, we will give each provide one report per patient to the doctors to let them know what have we discovered about these patients, whether the dosing needs to be changed or not. So this is how we report them. We give them the relevant clinical background of this patient first, the relevant cultures and MICs if available. We will let them know the assay results, the levels that we have found out. And we even plot out the free and unbound beta-lactam concentrations versus time graph for them. We worked out the PKs for them as well. And we will even put in, assuming 38% protein binding, adapting from a critically ill patient cohort for protein binding. All right, so we let them know that if you can change the dosing regimen to 1 gram Q12 infused over 3 hours, you will increase the likelihood of you achieving 20 milligram per liter for 100% of the dosing interval. And why 20? Because we are likely to know that the MICs here is about 4, all right? So that's why 5 times above MIC, that is 20. Okay, so that's why this is how we actually propose that you need to switch, or you should switch to this dosing regimen in order to hit a better PK/PD target for this patient. So currently we are going to RCT for our beta-lactam TDMs right now, and we are now doing not just beta-lactam TDM, we are looking at essentially antibiotics TDM involving all these antibiotics here. All right, we do fosfomycin, we do tigecycline, we do levofloxacin, we also have included ceftazidime, avibactam, ceftolozane, tazobactam, cefepime, astronam, piptazole, of course, doripenem, meropenem, and polymyxin B in one assays. All right, thank you.
Thank you, Dr. Kwa, for that excellent presentation.